Dr. Mohamed Hosny from Egypt, SCAD, when you have few solutions. Please adhere to time. Thank you.
Good afternoon, my dear professors and colleagues. It's a great pleasure for me to accept my case to be presented in front of you today. My case is named spontaneous coronary artery dissection when we have few solutions. Our patient is a 40-year female patient, housewife, married with 2 offspring. The youngest was 2 months old, so she's 2 months after her last delivery. She has a medical history of migraine controlled on medical treatment. She has also a history of epilepsy on sodium valproate. On 28th of July 2022, she was diagnosed as a non-ST segment elevation myocardial infarction at another healthcare facility, and she was transferred to our hospital for further management. And on presentation, her clinical examination was unremarkable, hemodynamically stable. This was her ECG on presentation. We can appreciate it was sinus rhythm with T-wave inversion in the precordial leads and the inferior leads. Her echocardiogram showed normal left ventricular ejection fraction with no significant valvular lesions. We went directly to the cath lab. This was the right coronary artery, was a dominant vessel with no significant lesion. And we went for diagnostic coronary angio to the left system. And from the left side, we can appreciate that in this epicaudal view that we have a haziness in the mid part of the left main with staining of the wall. Moving to the middle picture, we can appreciate that we have a tight lesion here at the junction between the mid and distal segment of the LED. And going upward, you can appreciate that the LED segment up to the left main was not normal. The last one was the spider view. So at this point, we were faced with 2 differential diagnoses. Either we did the left main dissection by our engagement, or the second differential diagnosis was SCAD, spontaneous coronary artery dissection. So to reach a final diagnosis, as the management is totally different between these 2 categories, we went for IVAS assessment. But here, we went with the EBU guiding 6 French femoral approach with left main gentle engagement, non-coaxially, with no strong contrast injection, moreover, and we went with the BMW wire we reached the distal segment of the LED, and we did the IVAS. Our IVAS here, this is a pullback from distal to proximal. We can appreciate that we have a crescentic shaped hematoma, changing its shape and site in a spiral fashion along the LED, starting from the distal segment and reaching the left main. As we can appreciate here, we reached the left main, and in the left main, we can appreciate that it is more concentric with dissection at 3 o'clock. So we have reached the diagnosis that we have a SCAD, mostly type 1. What goes with our case in the clinical presentation that the patient has migraine and has recent emotional stress, and she had a recent pregnancy. She was post-delivery. So at this stage, we stepped back for a while and start to think what to do next. We have 3 options: either conservative management, or to go for BCI immediately, or to go for heart team discussion. And as we are used to go for heart team discussion in our center, and putting in mind that immediate BCI may have a lot of complication, either iatrogenic extension of dissection or enlarging the false lumen and propagating hematoma. Putting long stents may predispose the patient to stent restenosis and stent thrombosis, and the very late stent strut malappositions that may happen. We went for the heart team discussion. Our patient here fall in this middle of the algorithm. She was clinically stable patient with left main dissection and a very long intramural hematoma till the end of the LED. We sit down with the surgeons, and finally we take a decision to go for conservative management as the patient was off chest pain, hemodynamically stable at the end of the diagnostic procedure. She was kept for 5 days in hospital, kept in therapeutic anticoagulation and DAPT, no chest pain further, and she was discharged for follow-up after 1 month. And during this month, we were searching for other vascular pathologies. But things sometimes goes the other way of our will. 1 day later, she presented with severe attack of chest pain and acute pulmonary edema. We can appreciate the diffuse ST segment depression in the pericardial leads and elevation in AVL. We went for coronary angiography, and this was unfortunately the findings that we have a spiral dissection starting from the left main, extending into the LED and LCX. Her echo showed ejection fraction of 35% with severe mitral regurg. Emergency cabbage was done, 3 venous grafts to the LED, diagonal, and the OM. Our surgeon told us that it was a very difficult operation, hardly reaches the true lumen of the vessels. There was a spiral dissection in all vessels. The patient was kept on mechanical ventilation, vasopressors with full hemodynamic monitoring. She was fully dependent on the intra-aortic balloon through the femoral axis. Her echo showed ejection fraction of 20% with global hypokinesia. She passed a very difficult ICU course with a lot of complications with acute renal shutdown, hypernatremia, severe thrombocytopenia, left pontine stroke, chest infection, acute bilateral lower limb ischemia, and finally, she arrested and died by severe sepsis. She stayed for 13 days post-operatively. My take-home message today is that SCAD is a peculiar cause of acute coronary syndrome. It may cause sudden cardiac death, especially in a young woman. Diagnosis is really challenging, and the coronary imaging was very helpful. There is a considerable uncertainty about optimal management, risk stratification, and the prevention of complication, and unfortunately, we have a limited solution to deal with this peculiar cause of acute coronary syndrome. And thank you for your attention.
Thank you, Mohamed. Mohamed, your
Thank you for sharing this case. I mean, it's difficult to be sure this is 100% SCAD. The way the appearance in the dissection, the left main, where the guiding catheter was there, the dissection starts from the left main all the way to the LED, so it might be heterogenic with the guy, we don't know. And sometimes when the dissection is against or with the flow, you always run that risk of the dissection propagating, as we've seen in this case. The second thing about sending for surgery, yes, the surgeon will have a very difficult time finding the true lumen, and quite often will end up going all the way distally. One way of dealing with this case would have been to seal that left main and just use a cutting balloon in the LAD to open the intima and empty the hematoma, then the patient will recover. But thank you for sharing.
Hani, then we'll come to Musa.
Very briefly, I think we will be fooling ourselves if we said that this is a spontaneous dissection. This is iatrogenic dissection. It behaves iatrogenic dissection. And if we say it's spontaneous dissection, we're doing disservice. Spontaneous dissection, I have never seen a spontaneous dissection that extends with 24 hours into that level of extension. And therefore, I would re-counsel of considering this is iatrogenic, spontaneous, it is iatrogenic dissection. Thank you.
Yes, a tip of the
Can I
gut.
comment?
One second. As if I noticed that you actually did you start off radial and then you changed to femoral?
Yes, we changed it. Oh, yes, we started with radial approach for the right coronary imaging, but the patient had a spasm, so we had to shift it during the diagnostic range to the femoral.
So did you try to engage in the radial
No.
system?
No. We didn't engage the left system from the right radial.
Okay, thank you.
And the engagement was very smooth.
Excuse me, Dr. Khashaba, please.
Yes, thank you for the case. The only thing that I will consider doing differently is not to keep the patient on therapeutic anticoagulation as well as dual antiplatelet therapy after the decision of conservative therapy. By this mean, we might have increased a little bit the hematoma and progression of the dissection itself. Because of the inlet presence near the left main, you might consider keeping the patient on single antiplatelet therapy. Otherwise, I would stop all anticoagulation and antiplatelet therapy as a part of the conservative treatment.
So, sorry, I'm not sure this makes any difference, because when you have antiplatelet on board, it takes 5 to 7 days for the effect to disappear. So it's really, you're talking about anticoagulation as heparin, possibly, but dual antiplatelet therapy does not make too much difference. I think, this is a case, it does take a brave thing to say, I'm not going to stent this left main and leave the dissection, particularly the direction of the flap, because it's against the wall, so the blood is still flowing and the flap is facing so the blood is always going to leak through.
Sorry, what is the indication of coronary angio from the start? I didn't get it.
Non-STEMI. It was a non-STEMI case.
Okay. So you didn't think about CT angio or something non-invasive in this young, because we usually suspect SCAD in this young ladies.
Thank you for this is very important point, but multi-slice CT coronary is usually indicated in low and intermediate risk patient, not in high risk patient. This patient was non-STEMI, was positive troponin and extensive ECG changes, so I think we should go for invasive coronary angiography.
Dr. Mohamed, thank you very much for your nice case. Thank you.